Finals SAQ2 Raised ICP. What are the symptoms and signs of raised ICP in an adult? Symptoms include headache, which is bursting and throbbing in nature, exacerbated by sneezing, exertion, and recumbency, worse in the morning after a period of recumbency due to increased PaCO2 associated with sleep and reduced CSF reabsorption. Other symptoms include vomiting and visual disturbances. Signs include respiratory irregularity, such as Stokes breathing, and neurogenic hyperventilation due to tonsillar herniation. Cushing's triad, consisting of hypertension with high pulse pressure, bradycardia, and irregular respiration. Eye signs include papilloedema, fundal hemorrhages, pupillary dilatation, ptosis, impaired upward gaze due to midbrain compression, and abducens nerve palsy, impaired consciousness due to caudal displacement of the midbrain. B. Describe the physiological principles underlying the management of raised ICP, 40 marks. The Monroe-Kelly doctrine states that the cranium is a closed compartment and the sum of its contents, which are the brain, CSF, blood and others, must therefore remain the same to avoid raised ICP. If the amount of one component increases, some compensation can occur by reducing the amount of one of the other components. Once these compensatory mechanisms are exhausted, ICP will rise, ultimately causing pressure on the brain, herniation and direct tissue damage. Physiological manipulation of the quantity of each of the components can limit ICP rise. Methods to reduce CSF includes diuretics, mannitol, hypertonic saline, elevation of the head of bed to 15 to 30 degrees, and CSF drain. Methods to reduce blood volume includes optimizing venous drainage by avoiding tight tube ties, head up tilt 15 to 30 degrees, paralyzing the patient to reduce Valsalva maneuver, treatment of seizures with anticonvulsants, avoidance of excessive PEEP and peak airway pressures, avoiding excessive arterial blood flow by maintaining PaO2, keeping PaCO2 in the low to normal range, anesthetizing the patient to reduce CMRO2, and avoiding pyrexia. Methods to reduce brain parenchyma volume includes the use of mannitol, avoiding hyperglycemia, and avoiding hypotonic fluid administration. Other measures include evacuating clots and excising brain tumors. Converting the cranium from a closed compartment to open compartment can be done via decompressive craniectomy. One of the main issues of raised ICP is its impact on cerebral perfusion pressure, where CPP equals MAP minus ICP, or CVP, whichever is higher. In the early stages of raised ICP, the effects can be mitigated by maintaining cerebral perfusion pressure through the manipulation of MAP and CVP. MAP can be maintained by avoiding dehydration and pyrexia and use of vasopressors to achieve a target MAP of 80 mmHg and above. CVP can be reduced by optimizing venous drainage, as described above. C. What are the methods used to manage or prevent acute rises in ICP? 30 marks. A. Airway. Intubate the patient. B. Respiratory. Aim for PaO2 more than 100 mmHg, PaCO2 of about 35 mmHg, and keeping PEEP less than 15 cmH2O. Hyperventilation to PaCO2 of 30 mmHg may be used for short time periods in emergency situations to reduce ICP. C. Cardiovascular. 15 to 30 degree head up tilt, tube ties not too tight, head in neutral position, sedation and paralysis if coughing or straining, maintaining MAP more than 80 mmHg. Neurological measures: ensure adequate sedation to reduce CMRO2, treat and prevent seizures, treat pyrexia, monitor and manage hyperglycemia, target blood sugar level 6 to 10 millimoles per liter. Drugs that may be used includes mannitol 0.25 to 1 grams per kg and hypertonic saline 5% 2 ml per kg. Surgical measures include CSF drain and decompressive craniectomy.